Next up is Dr. Majid Almadi. He's the president of the SGA and a consultant gastroenterologist at King Khalid University Hospital. And he's going to be talking to us about management of post-gastric sleeve leaks with SEMS.
Bismillah ar-Rahman ar-Rahim. So some of you might have heard this talk last year. It was given by Dr. Abdurrahman al-Jibrin, but we wanted to update it a bit. I think we have more data to talk about it, and I think the trend is in the country that we're seeing more and more bariatric surgeries being done, and mostly it's laparoscopic sleeve gastrectomies. And that's been the trend even in the USA. And over the last few years, we've been seeing more and more complications. Whether our complications are adequately in an acceptable range or not, we're not really sure, because there's no real track record of what's going on in the country. So laparoscopic sleeves are taking over other modalities of bariatric surgeries. So the major site of leak usually is in the proximal stomach. And we classify them time-wise, and this was a consensus by bariatric surgeons, and I'm not sure if it's based on any evidence, but they classify it as acute, which is within a week of the surgery, or early, up to 6 weeks is considered an early leak. Late leaks are more than 6 weeks, chronic more than 12. This type of segregation is important for the management. We know our endoscopic interventions are pretty good for early leaks. Acute leaks, there is a role for a repeat surgery. Late leaks, our endoscopic interventions are less likely to achieve success, although we might even challenge that, as we're going to go over some of the data we have. So the majority of leaks, more than 80%, are usually proximal. Distal leaks are more complex and difficult to manage, but they occur much less likely than proximal leaks. So the incidence of leaks depend on the literature and where you get it from and the volume. Some report none, while some report up to 7% of leaks. I think the reality is something in between, and what's acceptable is something around 1 to 2% is an acceptable range. Also, nobody really segregates these processes, but primary bariatric surgeries tend to have a less complication rate rather than repeat surgeries. So a person who had a gastric band ligation, then a sleeve, are more likely to develop complications than a person who had a primary sleeve gastrectomy. This is how it looks on a contrast study. So you've got your esophagus, you've got this fistulous tract that contrast leaks through into the peritoneum, and you've got the remnant of the stomach outlined by the remainder of the contrast. Endoscopic interventions are mostly, what's reported is using endoscopic stents, depending on the modality, but it works as a conduit, so gastric secretions and oral intake, hopefully, can pass through the leak without any complications. So secretions pass through the stent, bypassing the area of the leak, so you can go on for enteral feeding, and at the same time, you allow some time for healing of the fistulous tract and the opening. The type of stents we have and we use, they could be uncovered stents. These are totally not used for these types of interventions. If you use an uncovered stent, it's going to be impossible to remove. Fully covered stents are used, and partially covered stents are used. Each has their pros and cons, and we're going to go through them in a second. A new advancement in the point of stenting is using a mega stent. These are fully covered silicone metal stents. You position the proximal stent in the mid-esophagus, the distal portion either pre-pyloric or in the first part of the duodenum, depending on your style. And we've learned how to use mix and match which cases to use which technique. These are much larger than your conventional esophageal stents in diameter and much longer, up to 23 centimeters. They're different from your conventional esophageal stents that they're covered by silicone from both sides of the wire. So their removal is much easier even than the partially covered stents, and equivalent almost to the plastic stent removal. Plastic stents have been used. They do have their drawbacks. If any of you have used plastic stents before, Loading them is a pain, and deploying them is even worse. It's a stiff type of stent that you do run into troubles sometimes when you try to deploy them. So what we do usually in the process of treating people with esophageal leaks after bariatric surgery is we do one round of stents, and the round depends on what type of stent you use. If you use a partially covered stent, then we insert the partially covered stent, keep it for 6 to 8 weeks, then insert a plastic stent. You get a tissue ingrowth within the stent. It's almost impossible to remove without putting a second stent through the first stent and causing tissue necrosis, so to facilitate removal. You keep the plastic stent in for another 2 weeks, then you remove both at one go. And that's one round of stenting. If you use these mega stents, then a round of stenting is simple. You just put it in, keep it for 6 to 8 weeks, then you just remove it. You don't need to put another stent through. So, a person presents with a leak, he's sick, he's suspected, you admit the patient, you give him supportive care. Whether they're so sick that they need intubation, ARDS, pleural effusions, they can be pretty sick when they present. Or they can be somewhat okay. Either way, you provide supportive care, you start antibiotics, you get your interventional radiologist to intervene to drain any types of abscesses or collections that are intra-abdominal. Then you put your round of stenting. Hopefully they get better, either start nasojejunal feeding or oral feeding, and they leave home. And then you go on with your continuous management. What we do is these stents, if we're talking about deploying them, you're deploying them blindly under fluoroscopy, so you don't know where the leak is. So we mark it. Either we're lipidol, which we used to do in the past, then we started using clips. It really doesn't matter. You just mark where the area of the leak is. Then you put your stent through fluoroscopic guidelines and deploy it, as long as you bypass the area of the leak. After deployment of the stent, this is how it looks. It's clean, it's nice. And radiologically, you can see this air pocket that goes with the leak. You can see the stent crossing the area of the fistulous tract, so that it's even obvious on a CT scan. But after 6 weeks, you can see the tissue ingrowth on the stent. So removing these things directly without putting a second stent in is almost impossible. But although we do attempt it a few times, and it does work, but it can be a heart-wrenching experience to pull a stent out of the esophagus. It's not a pleasant experience. The problem with these stents is they do tend to migrate. And you can see here that the area, that marking of the leak, and the stent went lower than what we would like. So what we do is either go in, try to adjust it, but if it's been there long enough, you can't readjust it, so you put a second stent in. And that's what we do here. Just put a stent within a stent and telescope it. After the 6 weeks, you go in again and you put a plastic stent. The plastic stent overrides both edges of the metal stent. So this is the metal stent edges, and your plastic stent edges extend beyond both edges. So just to induce tissue necrosis. And after that, you remove the stent, either by invaginating it, like a sock type of removal, or you pull them directly in an axial fashion. This is how it looks after you remove the stents. So you see the indentations of the hyperplasia, and the fistulous tract disappears. Now, we do have a lot of controversy about the best way to do it. There are a lot of studies in the literature out there, but they clump leaks all together. So post-surgical leaks, post-anastomotic leaks, Boerhaave syndromes, and they're a different type of population. I don't think it's proper to clump them all together. The pathophysiology is different, the patient population is different. A person who had a resected tumor is not a patient who had a sleeve gastrectomy. But either way, anastomotic leaks compromise in this study only about 50% of what they reported. Technical success for these stents, putting a stent in is almost 100% successful. Removing it is almost 100% successful. The point of sealing is only 88% after you remove the stent, so a clinical success after the removal of the stent is only 88%. Complications, tissue growth definitely happens with the partially covered stents more than the fully covered or the plastic ones. Migration rate is higher with the fully covered stents and the plastic stents. And clinical success is almost the same. there is no variability whether you use a fully covered plastic or a partially covered stent. But it's something to keep in mind that the mortality rate is pretty high. We're talking in the range of 10 to 20% mortality rate of these patients. Again, this is a meta-analysis of leaks post-bariatric surgery. So these are pure bariatric surgery patients. Only 67 patients are included in this meta-analysis. And you can see that the clinical success is about a proportion of leak closure, the success of the closure of the leaks is about 88%. We'll just talk about our experience at our institution. We've got an active bariatric surgery group that gathers all the complications from all over the country. So over the last few years, we've gathered 64 leaks. They're about 36 years of age on average, but we do have older individuals up to about 65 to 70 years of age who had sleeves. Their BMIs, by the time they reach our institution, they're about 40. And they do have a milieu of comorbid illnesses, although not to the degree you would expect. So the majority were hypertensive. Some had both hypertension and diabetes. Half and half were both genders. And about 13% had a prior some sort of bariatric intervention. The time from the surgery till diagnosis is about 2 weeks on average, some of them very late, but even in the literature there are reports of a leak after 2 years. Findings on the CT scan when they presented, the majority had contrast leak that was obvious on the CT. To a less degree, half of them had abscesses, free fluid in the abdomen, and a good chunk of them had pleural effusions. So the time from surgery till diagnosis, as we said, is about 14 days. The time from surgery till the first stent is about 16 days, 15 plus minus. And the size of the leak on average is about 1.5 centimeters, but we had a case up to 13 centimeters as a leak. After the stents, the majority had nasojejunal feeds. Some had oral feeding, that's about a quarter of them, and a very minority of them needed TPN. Duration of hospital stay is about 2 weeks, 2 to 3 weeks on average, but some of them extended for more than 3 months. So this is how it worked. So these people come in with a leak. After a first round of stenting, about 84% sealed their leak. 10 of these 64, that's about 16%, still had the leak after the first round. So they went for a second round of stenting. So we do the same process again. And out of those, only one of them, which is about 2%, did not seal after a second round, and we went for a third round. And it worked after the third round. And that case was a bit complicated. This is him. He already had a band before. Then he went for a sleeve gastrectomy, and this is how the leak looked like. He had 2 leaks, at one in the GE junction and one lower down in the posterior wall of the stomach. And this is the scope through the defect itself, and you can see the radiological drains that were obvious. So we went to the peritoneum, washed as much as possible, came back. He went for 3 rounds of stenting. Because of his 2 leaks, so he had 2 sites at the same time, we had to cover the whole area with 2 stents, telescoping into each other. We didn't have at that time the mega stents that would go long enough, so we had to use 2 stents. After removal of the SEMS, it worked very well. So the overall success for our procedure is about 96%. Success after the first round of stenting was about 84%, and after the second stent was about 90%. Now, complications. Migration was about 13%, a bit lower than what was reported in the literature. Erosions, obstruction from the angulation of the stent itself. Perforation that happened in one patient when inserting the plastic stent. It's a rough stent to insert, and at that time the patient developed perforation. We just managed him conservatively and things went well. Bleeding, it was one patient and she passed away. It was a massive GI bleed. The stent caused a aortoesophageal fistula. This is the case that had bleeding. At the time she presented, the fistulous tract was obvious, the site of the leak. We put a stent in, it looked fine. After a while, this is how it looked after deployment. Looked pretty good, nice position, we were satisfied with it. And she came back a while later with GI bleeding. At the time we did the endoscopy, we found blood in the esophagus. They couldn't localize the bleed, but a CT scan showed that there was a clear indentation of the edge of the stent on the aorta. We were suspecting that there was some sort of a fistula, so we went for an angiogram that didn't show anything. So she was bleeding episodically. It was an on and off type of bleed. Either way, the patient went to surgery. They opened her up. They closed the site of the defect, but she did not survive the operation itself. So the bleeding was stopped. The operation time was pretty long, and she didn't tolerate the procedure. So we're not sure what type of stent we should use. And we started an RCT. I'm not sure when we're going to finish it, to find the proper power to differentiate between fully covered stents and partially covered stents. It's going to be difficult, but we've started enrolling patients. We're up to 10 now, and I think we should be over maybe in a few years. So modalities of treatment other than the usual stuff. So people use stents or use these Ovesco clips, these bear claw clips. They don't work so well in bariatric leaks. Some people have claimed success. It's still to be seen. Some people use these together. So they put a clip on, then they deploy a stent, or they do use it sequentially. So they put a stent on, after they remove the stent, and if there's a sustained leak, they put a clip. Another modality that's been coming in the literature is using double pigtail stents. So you put a wire through the defect, put a double pigtail stent, either one or two, keep it for 4 to 6 weeks, bring them back, remove it. If it heals, fair enough. Otherwise, you go for another round of stenting. On average, people need about 2 to 3 rounds of these procedures done. All of them need nasojejunal feeding, and their hospitalization time is pretty prolonged. Whether it works or not, we'll still see. So you can see here that it depends on the type of surgery that you have. Some people, on average, people need a long time for these stents for these leaks to heal, whatever modality you use, and depending on the surgery. But on average, we're talking about after 90 days of the intervention, about half of them, 50 to 60%, close their leaks. Some of them went up to 240 days of interventions just to close their leaks. And Roux-en-Y's do worse than sleeves. And gastrobronchial fistulas, we had one case of that, takes a longer time. So in conclusion, using stems are effective. It's an effective modality for laparoscopic sleeve gastrectomy leaks. They do have complications, and they might be grave. There are no head-to-head trials comparing which modality is better, and I doubt we're going to see one soon, but we hope we're going to have a better, clear literature in the future. And thank you very much.